Okay, a big thanks to the organizers for the kind invitation. So this is not an uncommon scenario in our current everyday practice. We're faced with complex distal left main bifurcation lesions in patients who you discuss in a heart team MDT and you decide for one reason or another that you should proceed with PCI. So there is a wealth of data demonstrating superior morbidity and mortality if we use imaging in left main PCI, meta-analysis and randomized data. And it starts off with sizing. So once you know your landing zone sizes, both left main, LAD, and circumflex, you can better formulate your strategy. It's very important you have a very accurate size so you can choose your stent. And then you need to know your equipment. How big do my stents go? How big do my cells go? There's no point doing a DK crush and putting a 4mm stent in the circumflex if the cell in your left main only opens up to 3mm. So you need to know what you're using and what sizes you're going with. Once you know your sizes, you can choose your platform, you can choose your size of stent, you can choose the correct two-stent strategy, whether you want to downgrade from culotte to crush or upgrade depending on your size. You can size your pot and you can size your kissing balloons. Even if you're using a single stent strategy, you can size your side branch balloon. So we go back to this case. We identify our proximal and distal landing zones in the LAD. We know it's a 4mm vessel that needs to go up to 4 or 5 proximally. We measure the length from our landing zones and it's just under 23mm. So I'm going to take a 4023 stent and take it up to 4 or 5. You go to the circumflex, we size our landing zone, it's about 3mm. You measure from your landing zone to the ostium, it's just over 12mm. So I'm going to go a little bit over it so I can crush it into the left main. So we also know our circumflex stent. Well, does it fit in with my strategy? Yes, because my LAD stent, the cell will go up to 4.5, so a 3mm stent is good. We're good to go. Here we go with a DK crush stent, and we go ahead and we reassess post-procedurally. We measure our expansion in 2 ways in left main. First, you look at your relative expansion compared to your reference vessel. And here we're 100% expanded, except in the LAD we're 94% expanded, more than good enough. But you also look at the absolute value, because there is data to suggest that an absolute value in your left main, LAD, and circumflex correlates very well with your restenosis rate. And in a large individual, you want an MSA of 10 in the left main or more, 7 in the LAD and 6 in the circumflex. In a smaller individual, especially in a Southeast Asian population, you can go with slightly smaller sizes. And this is our result in this patient. Imaging is also quite useful in upgrading or downgrading your bifurcation. So this patient has very complex left main LAD circumflex disease. And to me, angiographically at least, I felt that the circumflex is likely severe. So when we formulated our strategy, we started with IVUS interrogation of the circumflex. And we can see that the MLA at the proximal circ is 4.8, which to me is not severe. This helped us downgrade our bifurcation and take a single stent strategy where we just stented LAD to left main and did kissing balloons with a good outcome. This is a different case, again a high-risk patient with a dominant circumflex, so a left dominant system. With this equivocal circumflex lesion, in the ariochordal it doesn't look too bad, in the spider maybe it is a bit bad, and it's very important to know whether it's severe or not. In this case, the MLA in the circumflex was 3.2 in a dominant circ, so it is significant. So we go ahead and we get all of our other measurements, and in this case, the circumflex and the LAD are relatively equal in size. We go with culotte stenting, and we come back and we do our measurements. So it helped me upgrade from a single stent to a 2-stent strategy now that we know that the circumflex was severe. And this is our final result. Imaging can also help you predict your side branch occlusion rate. So there are traditional predictors that you can see on both IVUS and OCT. If you have significant disease at the ostium of the side branch, double the risk of occlusion. Significant disease in the main vessel just before the side branch doubles the risk of occlusion. But there are additional things that you can find out on OCT that also help you. So in OCT, you can look at the carina tip angle. A tight angle correlates with losing the vessel. And you can also look at the branch point to the carina tip. The shorter the distance, the more likely you are to lose a side branch. So in general, a tip angle of less than 50 and a distance of less than 1.7 gives you a better prediction as to whether or not you're going to lose the branch. In left main bifurcation, your branch could be the LAD or the circumflex, so it's not a small diagonal that you might lose, and in which case you want to go with an upfront 2-stent strategy. Moving on to physiology. We are not as good as we think we are at assessing left main disease angiographically. There is a large intra-observer variability between all of us. We will look at the same left main. Some of us will think it's moderate, some will think it's severe, and some of us will think it's moderate severe. It's absolutely vital that we know. And there are multiple factors, such as the fact of eccentric disease, angulation, bifurcation anatomy, that makes it very difficult to assess. So let's look at this case. This patient came in with an ACS clearly due to the LAD. But during coronary angiography, there is this eccentric distal left main disease. And initially, as I looked at this angiogram and I studied it, I just wondered, is the left main significant? Should we stop here and discuss it in MDT, whether we should think about bypass surgery or left main PCI, or is it not? Now, luckily, the circumflex does not have severe disease. So we did a pressure wire from left main to circ, and the FFR was 0.97. But we have to be careful. Severe LAD disease can affect your FFR in the left main and the circumflex, but not this much. It won't downgrade a 0.97 FFR. So we proceeded with image-guided stenting to the LAD and a drug-coated balloon to the diagonal, thinking that the left main will be okay, and then we repeat the FFR afterwards, and the FFR is 0.9. So we're quite happy now that the left main is not significant, and we've downgraded it from a very complex left main bifurcation to just simple LAD PCI. But we do have to be careful, because left main disease rarely comes isolated. Quite often you'll have concomitant disease in the circumflex and in the LAD, and it can be difficult to assess. So this is a very interesting case that I did a few months ago, where this patient has critical angina and recurrent acute pulmonary edema, ischemia driven. There is some left main disease. I don't know if it's significant or not. It's calcific, it's eccentric. There is what appears to me initially to be this moderately severe mid-circumflex disease. I didn't think it was angiographically critical. And there's, of course, this severe proximal LAD disease. So we started off with our pressure wire assessment. And the first thing is we did an IFR pullback of the circumflex, and it turns out that this lesion is actually very ischemic. But you'd be interested to see that there's very little ischemia in the very proximal circumflex or in the left main stem. We do the same for the LAD, and the LAD is extremely ischemic. The IFR is 0.5, and again, the majority of that ischemia is in that mid-vessel. It doesn't include the very proximal LAD or the ostial LAD or the left main stem. So based on this, you can say, well, the strategy is just to treat focally these two segments of ischemia, and we should be okay. So we go to the circumflex, we do our IVUS interrogation, and yes, the lesion is very severe, much worse than I thought it would be angiographically. We've got very clear landing zones proximally and distally, and we're going to go ahead and treat this. We do IVUS of the LAD, and if you look at your proximal and distal landing zones, again, you've got very good, reasonable landing zones to land in. But the very proximal LAD, just beyond the ostium, has an MLA of 4.2. Now, this is a small caliber female, rather than a large 6'5" man. So it's a small caliber female with this moderately severe proximal LAD lesion, and the distal left main has an MLA of 7.6. So we felt it is not unreasonable to focally treat the LAD, right? And then we reassess. So this is what we did. Image-guided IVL, PCI with optimization to both LAD and circumflex, and this is our angiographic result. Now at this point, the operator, myself, turns to his team and says, staff, this is how we do physiology PCI. State of the art, we know where the ischemia is, we've done a good job, now let's just check again and do another pressure wire to prove that we've done what we needed to do. We know where the ischemia was and we treated where the ischemia was. And so I do a pressure wire of the LAD, and this is what you get. Wait, hold on. So the LAD is ischemic still. It used to be 0.5, but it's now 0.8, but it's still ischemic. It's an ischemic LAD, and now the ischemia is very proximal. It's at that distal left main ostial LAD junction. And this is what we had before we started. And that's what we used to formulate our initial strategy. And this is how you're thinking in the cath lab. So come on, man. You know, we did what we were supposed to do. But this is not unexpected. So we know when we do an FFR that your proximal lesion will affect your distal ischemia. But we also know that your distal lesion affects your proximal ischemia. And now that you relieve the distal obstruction, the proximal obstruction becomes more significant. And this is very well documented. So in this case, we go back and we do a provisional stenting from LAD to left main with kissing balloons and optimization, and we repeat the IFR, and this time the IFR is 0.97. So in summary, intravascular imaging improves procedural and long-term outcomes, including mortality, all-cause mortality and cardiac death in left main PCI. Imaging to help you with your bifurcation strategy, sizing is absolutely vital. sizing to determine which stent you're going to use, which platform, which size, and what's the most appropriate two-stent strategy. It can help you upgrade or downgrade your bifurcation. It can help you predict side branch occlusion, where you might want to go with upfront two-stent strategies rather than a suboptimal bailout strategy. Physiology helps you assess the hemodynamic significance of intermediate disease and ensures optimal hemodynamic results post-PCI, but we do have to exercise caution in serial lesions because left main disease rarely occurs on its own, and quite often you have to reassess once you've treated to see if you need to treat the other disease. What we didn't have time to present today, and what will be very important in the future, is the emerging role for drug-coated balloons in left main PCI, and I think this may well change the way we look at our strategies in the future. Thank you.